madam, Narmada,
Good evening, ma'am.
all my seniors,
Ramachandra sir.
Ramchandran sir.
PRC sir, thank you.
Good evening. Good evening,
sir.
everyone.
Good evening.
Good evening. Good evening.
sir.
Good evening. Very good evening.
ஒண்ணுல நீங்க வந்து உங்களை வந்து
Nice to see you all. Good evening.
slide sir.
என்னம்மா? ஏன்? ஓஹோ, எனக்கு என்னுடைய ஸ்லைட்ஸ் என்னது இதுல இல்லையே. சரி, ஸ்லைட்ஸ் ஷேர் பண்ண சொல்லியிருக்காரா?
சார் ஜாயின் பண்றாரா நர்மதா?
மேம் சாரி மியூட்ல இருந்தேன் சார். 2 minutesல ஜாயின் பண்றாரு மேம். அவருக்கு ஏதோ டெக்னிக்கல் டிஃபிகல்டிஸ் மேம்.
ஓகே.
Good evening, Dr. Vishwanath.
Good evening, sir. Good evening.
Good evening, Achu.
Good evening. Good evening, sir.
Good evening, Sendil sir. Jalal.
Sir, வணக்கம் சார்.
வணக்கம் சார்.
வணக்கம் சார். செந்தில் சார் வணக்கம்.
எல்லாருக்கும் வணக்கம்.
வணக்கம் சார்.
வணக்கம் நர்மதா.
வணக்கம் சார்.
சார் வணக்கம். சிறப்பு சிறப்பு சிறப்பு.
Good evening, sorry. Good evening. Sorry, I was just
Good
trying
evening.
to
Good
figure out
evening.
something.
Good evening.
ஷேர் பண்ண சொல்லி.
Good evening, Dr. Janani.
Good evening. Good
ராஜு
evening.
சார் நீங்க பாதர் பண்ணிக்காதீங்க, நான் ஓபன் பண்ணிட்டேன் இந்த ஸ்லைட்ஸ்.
சரிங்கம்மா, சரி.
சார் ஜாயின் பண்ணிட்டாருன்னா ஸ்டார்ட் பண்ணிடலாம் சார்.
Yeah, yeah.
சார் வணக்கம் சார். தம்பி சோமசுந்தரம் வணக்கம்.
வணக்கம் சார். நான் முதல்ல சொல்லிட்டேன், நீங்களே சொல்லிட்டீங்க.
அப்படியா?
பயணி
மியூட்ல இருக்கீங்க பழனிராமன். ஹாய் கண்டமாறன்.
வணக்கம் வணக்கம். ஆமா,
பார்பிடோஸ்ல இருந்து ஜாயின் பண்ணிட்டிய?
ஆமா, நல்லா இருக்கீங்களா?
தேசம் விட்டு தேசமா?
மேடம் யுஎஸ்ல இருக்கீங்களா, இங்க இருக்கீங்களா?
இங்கதான் இருக்கேன்.
கிளம்பிடுவாங்க சார்.
என்ன மேடம் யுஎஸ் போயிருக்கீங்களா?
யுஎஸ்ல இருந்தா எனக்கு ரொம்ப நல்லது. நான் 10 மணி மீட்டிங் 11 மணி மீட்டிங் எல்லாம் அட்டெண்ட் பண்ணுவேன். உங்களோட லேட் நைட் மீட்டிங்ஸ் எல்லாம் ஈஸியா அட்டெண்ட் பண்ணுவேன். எஸ்பிஎஸ் என்ன ஆச்சுமா?
தெரியல மேம், அவர் ஏதோ டெக்னிக்கல் டிஃபிகல்டிஸ்னு சொன்னாரு மேம். திருப்பியும் நான் மெயிலும் பேனலும் அனுப்பிட்டேன். திருமுருகன் சார் நீங்க ஒரு தடவை அனுப்பிடுறீங்களா? அதுக்கும்
பேனலிஸ்ட் லிங்க்ங்களா?
நான் அனுப்பிட்டேன் 2 தடவை.
Narmada, while waiting for us to join, you can just start the all introductory process, no?
Yes.
இல்ல அந்த பிரேயர் கேர்லாம் முடிச்சிரு.
Yeah, okay.
Good evening, Dr. Dakshayani, Dr. Vinod Kumar.
Good evening, sir. Good evening எல்லாம் முடிச்சிடலாம் சார் வரதுக்குள்ள.
மாலை வணக்கம்.
A very warm welcome on behalf of Tamilnadu ID chapter, Pediatric Infectious Disease Academy chapter of Tamilnadu, and IAP TNSC. We are very happy to host the 5th academic event of this year, and we are very happy to be associated with IAP TNSC for this program. Now I request Dr. Dakshayani, Treasurer, IAP TNSC, to recite the pediatrician prayer to start this program.
Thank you, ma'am. குழந்தை மருத்துவனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயை துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணியுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றவும், நல்லனவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you, Dakshayani. Now I request
sir is joined. SBS sir is joined.
Thank you,
welcome, sir.
Welcome, sir.
SBS sir.
Now I request our chairperson, Dr. Janani ma'am, to kindly welcome the gathering.
Good evening, sir.
Good evening, all of you. I think this Tamil Nadu ID chapter, we've been doing a webinar suiting to the context that is prevailing in the city. So we thought tropical infections, we expect tropical infections to go up from July onwards. So we thought we'll have a panel on common tropical infections that is encountered in children. I think we decided the panel with Dr. SBS being the moderator. I think no one else is, well experienced in tropical infections than Sir. So we decided to make him the moderator. Thanks for accepting to be the moderator, Sir. And we have a elite group of panelists, all of them well accomplished and experienced in their own places of practice. Palani Raman, Nandini Kumaran, Raju Sir, and Somasundaram. I think we are going to have useful messages from this wonderful panel. Over to Narmada and the moderators.
Thank you, ma'am. I request, thank you for the kind words. I request Dr. Tirumurugan sir, Secretary, Indian Academy of Pediatrics, TNSC, to kindly give us felicitations.
Thank you very much, Dr. Nimura. As probably the most vibrant subchapter of IAP TNSC in Tamil Nadu, the ID chapter, I think they have been doing absolute justice to their activities, and the third Sunday of every month supposed to be the CMS. But unfortunately, this week, because we had a clash with other program, we had to move on and to a different date. But I'm sure it's an exciting session and we are all waiting to listen to the topic. So without wasting much time, let us move on to the topic. So thank you very much for the opportunity.
Thank you. I would request very short felicitation from MS Vishwanathan sir and Senvil sir, our central executive board members of IAP TNSC.
Vishwanathan.
Good evening. Good evening. Thank you very much. And please carry on with the program. Thank you.
Thank you so much, Vishwanathan.
Senvil sir.
வாய்ப்புக்கு நன்றி. நம் நிறைய கத்துக்கணும். அதனால நம்ம இதுக்குள்ள நுழைவோம். அன்பான வாழ்த்துக்கள்.
நன்றி.
Dr. P. Ramachandran sir, our patron of PED Academy of Tamil Nadu. Ramachandran sir, your short felicitation.
Thanks so much. Best wishes for the program. So we are all very eager to learn.
I think we'll start, Narmada.
Yes. A very short introduction to the panelists. Of course, Dr. Subramanian doesn't need any introduction at all. Director of KKCTH, he's a very astute academician and pediatrician, and he has been the teacher of teachers, guiding us so far. And he has also been the chairperson in 2022 of National Infectious Disease Chapter. He's got a very elite panel of Dr. Nandini Kumaran, whose madam is practicing for the past 36 years. The basic idea we wanted this panel was to have the practitioners to give us an insight into how they manage in their clinical practice. So no better than to have Nandini Kumaran ma'am, CMO's pediatrician. She's a national winner of IAP Practicing Pediatrician Quiz. Everybody knows her. She has received the Tamil Nadu State IAP Active Pediatrician Award, as well as IMA Lifetime Achievement Award and Academic Excellence Award. Dr. Raju sir, he's a CMO's pediatrician from Tirunelveli. As soon as this topic came from the south, only his name occurred to me. He's a director, Krishna Maternity and Childcare Center. Being in such a place, he has really converted that into a DNB accredited hospital with training many doctors and nurses under his care. And even his sons, two of his sons, neonatologists, and one is an intensive care person, is doing a lot of work in the same field. He's also the recipient of Jayaraj Ayanad Oration Award in 2017, which was full of his practical experiences. He's an author of many articles and publication and an alumnus of ICH. Dr. Palani Raman sir, no better than the person to join in this elite panel. Sir is known all over India for his academic skills, as well as he's a very devoted student of Dr. Ambedkar, and he's a teacher to many of us here. He's published many articles to his credit. His experience as a general practitioner for more than 30 years will add value to this panel. Not last but not the least, we have Dr. A. Somasundram, Dr. Consultant Pediatrician, Fortis Malad Hospital and Sabri Childcare Center. He was the executive board member of CIAP 2022 and 2020. He was also the secretary IAP Tamilnadu State Chapter. We all know that he was the national coordinator of the very practical module COP, and he's also the state coordinator of IAP Neurodevelopmental Chapter. So with his rich experience, all these faculty members, along with Dr. SBS, sir, as I said, it's going to be the blockbuster CME. for Pediatric Infectious Disease Academy of Tamil Nadu chapter. Over to you, sir. Sir, if you're not able to share the slides, can I do it for you, sir?
Yeah, please do that because there is some technical issue.
Yes, sir. I have downloaded the slides for you, sir.
Yeah, good. Thank you.
Yes, sir.
Okay. Thank you very much. Good evening, friends. Let me at the outset thank Dr. Janani and Dr. Narmada for the opportunity to do this session, a case-based discussion on tropical fevers. In fact, I'm very, very lucky to have such distinguished senior pediatricians as panelists. In fact, I as moderator have very little to do with somebody like Raju Subramaniam, Pani Raman, Nandini Kumaran, and Somasundaram around. But the tradition demands that the moderator should set the ball rolling. Next slide, please. Yeah, the session will last for approximately an hour and 15 minutes. And I assure you it won't last for more than 75 minutes. The focus will be basically a few case scenarios after an introduction about what is tropical fever. And the case scenarios will consist of a few dilemmas in diagnosis and treatment. And we will ask our experts to give their inputs. And in the end, we will have a summary. And if time permits, we'll take questions from the audience. Before we go to the case scenarios, next slide there, Dr. Namala. The term tropical infection is defined as infections that are prevalent in tropics. Tropics means, we know the definition where below the tropic you find the countries which unfortunately suffer from lots of infections. It's not because of the tropical climate, but also because of socioeconomic inequalities. This is the definition which has been agreed upon by experts. And the most common ones we know, they are our breadwinners, dengue, rickettsial infections like scrub typhus, malaria, typhoid, leptospirosis, and bacterial sepsis, including typhoid and some viral infections like influenza. Next slide, please. Though the term tropical infection refers to only such common infections, there are many uncommon illnesses which also can affect people in the tropics. But some illnesses like, those imported viral infections like Crimean Congo fever, Zika, etc., can also occur in the tropics. More importantly, human beings who live in the tropics, if they develop fever, they may have fever not only due to tropical infections, but also due to non-infective conditions like autoimmune or malignant conditions. Next slide. With this brief definition, without wasting our time, let me start with a case scenario which we would see commonly in day-to-day practice, where we have young children coming with fever with no clues. Tropic. This is tropical fever, isn't it? A child living in the tropics comes with fever, no clues, 2-year-old. The child is fatigued, intake is poor. Clinically, there is absolutely no clue to diagnosis. Everything looks fine except the temperature of, say, 101, 102. Nothing else is happening in the child. Let me ask Dr. Raju Subramaniam. Raju, is this tropical fever? In Tirunelveli, Raju, you have such busy practice. Parents are anxious, 103 temperature. What do you think are the common causes that you would think of in a tropical setting when a child 2 years old comes with fever without any clues? with only fatigue and poor intake. Raju.
Oh. Good evening, everyone. First of all, I would like to thank Dr. Janani Madam, Dr. Namada, and my friend SBS for having included me in this elite panel. And he has given a case scenario which probably every one of us, not in Tirunelveli, everywhere we meet in day-to-day practice. Probably this is the bread and butter of any practicing pediatrician daily. 3 days fever without any clue, fatigue, poor intake, no absolute clues for diagnosis, and fever had been documented. I suppose the fever had been documented. We call it as acute undifferentiated febrile illness, or in short words, AUFI.
Can I have the next slide, Narmada? Can I have the next slide, Narmada? Yeah.
So in which case, we'll first think of the common prevailing viral infections, because hardly a 3 days old fever. Having said that, we should not forget the other causes of undifferentiated fevers which commonly prevail in our tropic, namely the malaria, which is not very common in our area. We take it as a coastal infection. Typhus, which has become prevalent now and recently well diagnosed by many of the practicing pediatricians. Leptospira, again, it's not that common in this area, but very common in metros. Typhoid, which is almost always there, and dengue in various forms. And of course, I would like to include influenza also. This, I would say, it will come under the common undifferentiated acute febrile illness. And we will have this kind of short demand, ESR, namely the malaria, the arboviral infections like dengue, then enteric fever, the spirochetal infections like lepto, and rickettsial infections, typhus, etc.
Okay. Well, amongst all, please, can you go to the previous slide, Dr. Narmada? Yeah. Amongst all this, what is the most common thing you see in your practice? All of you, all experts can give their preference. Amongst all these 5, these are the, throughout the world, these are mentioned as the most common causes of undifferentiated fever. In your practice, do you think malaria, I mean, depending on the locality from which you are practicing, urban, rural, north, south, east, west, Raju, what do you think is your experience?
Now, I would say the dengue tops the list now, as of now. And almost second comes probably would be enteric fever. And the other things, enteric fever, typhoid fever. And the other things, of course, they come as the 3rd, 4th, and 5th priority.
Okay. You don't think the non-dengue viral infections are causing a lot of problems now, seasonally? That's what you are saying.
Yeah, that's the thing. That's the thing.
Okay. Let us go to the next slide. Yeah. Dr. Narmada, next slide, please. Yeah. Now, I said that undifferentiated fever basically is because of, the common causes which are mentioned in the previous slide. But in a 2-year-old child, if I were to ask Dr. Paniraman, which do you think, even in a tropical setting, which do you think is most often missed, overlooked in this scenario of undifferentiated fever? Is it malaria? Do you think we are underdiagnosing malaria? Or 2 days dengue, we don't think of it? Scrub typhus, we don't think of it? Or UTI? Dr. Paniraman.
Good evening, dear everyone. First of all, thanks everyone for the opportunity. And given the scenario of a 2-year-old with a 3 days fever, and this undifferentiated fever is a terminology taken from the adult. When it comes to less than 3 years, usually it is known as a fever without focus. When it comes to 3 days with 3 days of fever. When it comes to fever without focus in a small babies, you always think about, apart from the common viral illnesses, you think about occult infections, which are very common. That is occult bacteremia, occult pneumonia, and occult UTI. Occult bacteremia is no more relevant because of the vaccination of the pneumococcal and Hib vaccine, number 1. Number 2, occult pneumonia will have definitely will have a tachypnea, so that will give a clue. Number 3, the most common thing which is very often missed in practice is the occult UTI, which has to be always thought, because externally you don't have any localizing signs except for the fever and the vomiting and with the rigors or without rigors. So the UTI should not be missed, even though the topic given is a tropical fevers. The first and foremost, we should think about the conventional infections, that all the occult infections. So I think about the UTI, the common thing. When it comes to third day, then only I think about the malaria, dengue, and typhus. The malaria is out of my question in my area. For me, the scrub typhus and dengue is the other next two things. So first and foremost, I will always rule out in a given situation, the UTI the first.
Extremely well said, and I should appreciate Dr. Paniraman for bringing forth a very important concept. In fact, if one were to be asked, what is the most commonly missed, most commonly overlooked, underdiagnosed, undertreated infection, bacterial infection in children, the answer should be UTI, UTI, UTI. Even in a tropical climate, nothing prevents a child from having a non-tropical illness. It's a universal illness of UTI. There are 2 or 3 reasons why UTI is often missed. One, UTI below the age of 3 years need not necessarily present with urinary symptoms like dysuria, loin pain, chills, etc. In fact, when we were students, Nelson's textbook used to mention one of the types of diarrhea as parenteral diarrhea. The term is no more used. Diarrhea when there is otitis media, diarrhea when there is UTI, used to be mentioned in textbooks as parenteral diarrhea. And Nelson, I remember the 9th edition mentioning that pathogenesis is not known. Many a child with UTI can present with diarrhea and vomiting and may not have dysuria. In fact, in the literature, it is mentioned the most often present clinical clue to the presence of UTI other than fever is foul-smelling urine noted by the mother. It's not dysuria. So that's one of the reasons why urinary tract infection is often missed. And it's also important to remember the second point, unless you do a urine routine analysis, and third, unless you have the routine habit of doing a urine culture when there is no focus, when there is a febrile child below 3 years, you are likely to miss UTI, and that should not happen. That's a very good message from Paniraman. Okay, next slide, Dr. Okay, now having seen a case scenario of a young child having the so-called tropical fever, and Dr. Paniraman saying UTI is more common than the other causes of tropical fever. A child develops fever in a tropical area. We always know history is very important. Even urinary tract infection, history of foul-smelling urine, dysuria present is going to give a clue. There's going to be a rigor, you always think of malaria and UTI. And if there is a rash, you're always going to think of something like rickettsial infection or dengue. But history is very, very important, like any other illness. Dr. Nandini Kumaran, a very experienced pediatrician, I'm sure she would definitely give an appropriate solution of obtaining relevant history in tropical fever. Dr. Nandini and Dr. Somasundar, please. Thank you.
Thank you for the ID chapter for this opportunity. I think a methodical and a good history taking will give details about about the illness itself, because it's fever. You'll have to ask the duration of the fever, how many days of fever. It's just a few days, which is acute, or it is a very long fever as a chronic. And then
Narmada, next slide, please.
Details will go into the pattern of the fever. The pattern of the fever, you'll find out what was the onset of the fever, whether it started off very high at the beginning, which is very common with viral infections like dengue as well as malaria, some of the bacteria which localize to areas. And we also see zoonotic infections like scrub and leptospira also having a very sudden onset or abrupt onset of a high fever. Whereas if you have a fever, which is sort of mild to moderate only, and then by the day 3 or 5, we want to know the trend of the fever towards the end of the first week, that is 3rd, 5th day. If the fever tends to rise, normally most of viral infections like dengue, 3rd to 5th day, there is a downtrending. But if the fever tends to rise more and more, child also interfebrile period, if the child starts feeling sick and not eating well and not active or playing, those clues will give us a thing that it is probably bacterial. And so that, and also we will try to find out how about the feed activity, urine output of the child. We will try to find out what are the medications that the child has been taking before the child came to us, and prior to the onset of the illness, whether there is any drug history, because sometimes this fever may not be an infectious cause at all. It may be, as Sir said, as a person in a tropical area, it could be a allergic or a hypersensitivity reaction to a drug. So it is not only the drugs during the illness, we have to ask them prior to the illness within the last month, whether they've been taking any thing. One common example is taking an anti-epileptic drug, which can produce in hypersensitivity reactions after about 2 to 4 weeks. So that is the DRESS syndrome type. So it is medicines given for the fever prior to the onset. We'll try to find out contact, whether the family members or the neighborhood there is outbreak of illnesses, and also from which geographical area they are coming, and whether there is some outbreak of some recent outbreak of any illness over there, and whether recently they have got, suppose they come after a holiday, whether they have a travel history. The disease is not that common in our locality, but they have obtained it from an area where they have gone, they have visited a farm, etc. They had some animal contact, whether they were, and it is after a monsoon, or if it is after a flood, then we will drinking water or a contaminated food. All those things, or walking barefooted, waddling in a floody area after monsoon rains. All this will give us some clues for potential exposures, and also try to help us in sort of trying to help us in the diagnosis as we go through the thing. And this is all about the details of the fever and how other aspects. But we also have to look something about the host, whether the host is an immunocompetent person in the past history, whether there were some recurrent infections, or the child has not been a reasonably well child, an immunized child, that is also important, versus an immunocompromised child nutritionally with PEM or obesity, or the child has got some comorbids like diabetes or any underlying neoplasms. Is the child on any immunosuppressive drug? Whether the child has undergone something like a splenectomy, which makes the child prone or puts the child into an immunocompromised state. So we'll take details about the history of fever and all the details about the pattern of the fever and other things. Secondly, we will look into the host aspect about the competence and the compromised state. That would be my approach, sir.
Okay, very well said, Dr. Nandini. In fact, if you ask me, the most neglected part of history in a child with tropical infection is probably tropical travel history. That's something we should not forget to ask the parent. In fact, I remember a personal experience about 25 years back when I was in Ramachandra. A doctor's child got admitted with fever, and the mother was working in Chennai. The doctor was from Mangalore, and the child had gone on a holiday for about 15-20 days to Mangalore, come back with fever, had anemia. We were all thinking of malignancy. The peripheral smears are negative. And we forgot to take the travel history. We forgot to take the travel history of the boy going to Mangalore. And those days, Mangalore was endemic for falciparum malaria. In fact, hemoglobin is low, platelets were low. We were thinking of malignancy. We did a bone marrow. We could pick up the falciparum only in the bone marrow, not in the peripheral sphere. If we had taken proper travel history, we would not have done bone marrow. We might have given anti-malarial treatment with better lookup for pickup of malaria. That is one. Similarly, children these days, parents now, most companies give travel holidays free. They go to jungles and come back. And as you rightly said, paddy fields, waddling, and some rainwater exposure should make you think of melioidosis or even leptospirosis. And jungle forest stay should also make you think of rickettsial infection. And of course, the other history, which is often forgotten, is exposure to animal milk in brucellosis, animal bites like dog bite, etc. That is very important in the history. The other thing which is important for us to remember is that these textbooks describe so many types of fever, perlepsin fever, periodic fever. I mean, the pattern of fever very rarely helps in the diagnosis. It's very rarely. And last but not the least is the seasonality. In fact, in Chennai, if a child comes with fever between April and June, we generally don't think of dengue. We think in terms of typhoid more often. But then the same child comes between September to November, dengue will be the first diagnosis. So these are all some of the points which one should keep in mind. I'm going to ask Dr. Paniraman as well as Dr. Raju and Somasundram. In your experience, have you picked up the diagnosis of the tropical infection with some bizarre history? Can you recount any example like what I said just now? Raju, Paniraman, and Somasundram.
Yes. Because in our area, people travel quite a lot. Most of them, they work in metros like Mumbai, Chennai and all. The first probably, as you said, the most important history we would ask would be the travel history. Invariably in those days, when you do Mantu in those people who come from Mumbai, it is almost like 90 to 95% positive. Used to be very highly positive. And we would probably people practicing in Tamil Nadu would remember those people who have migrated from Mumbai or who have come on a holiday, we can easily pick up many forms of tuberculosis in those days, and also malaria. So that is my experience.
Sir, endemic infection is one which is easily picked up by a travel. When they go to a place, they come back after having a few few days of cooked food from the hotel, and then they come back with an history of fever, prolonged high spiking fever, increasing fever with constipation, and then followed by a diarrhea. So probably you can think about a endemic fever. So history wise, outside prolonged intake of food from the hotel can be extreme after a travel on a vacation, sir. This can be on.
With respect to me, as you told, about 10-15 years back, I had a child, school-going girl child, presented with anemia and breathlessness. And finally, when we examined, there was the peripheral smear showed plenty of gametocytes. On asking, the patient was hailing from Ramnath, had gone to Ramnath, their grandfather's place, so which is a malarial endemic area. So that retrospectively got the history. In the same way, what all the malaria cases I had are all mostly from like Kottaval Chavadi area of Chennai or some like that, like Ramnath area or coastal areas. So this was the experience I had. That was a real nightmare. That case was a black water fever. It presented with the black water fever and finally settled very nicely with the thing those days. So that was my experience of 15 years back, and had a habit of looking at the peripheral smear and got the gametocytes.
Sir, I have had an experience of a child who was diagnosed later as rickettsial fever, but then they had gone for a trek to forest near Mysore. And probably we do not know that they would have got it from over there, because we hardly see directly from Coimbatore. These are people who come from other areas that we see the rickettsial disease.
Okay. In fact, in a lighter vein, there used to be times when we used to suspect rickettsial infection only when parents and children visit the jungle or forest area, etc. Nowadays, because we have moved into jungles and occupied the animals' land, the animals are coming into our houses. So I don't think tick bites and all these rickettsial infections are absent in Chennai city. We have seen enough number of children from Chennai city, heart of Anna Nagar, Nungambakam, Srinagar, West Mambalam, coming with rickettsial infection. I think it exists everywhere. That is one. Somaswaram, you want to add anything more on the history?
Sir, ma'am has highlighted everything. So put it in concise forms. So just have to think about only 3 things as a main causes for you to get an tropical infection, because only 3 things. One is a bite, insect bite, mainly a mosquito or a tick or a mite. The second thing, an ingestion of a raw undercooked or meat or something like undercooked water and a milk. So that is an ingestion part. The third part will be an exposure to a rodent excreta, that is mainly a leptospirosis or some other causes like Legionella or something like. So the 3 things has to be thought of: an insect bite, an ingestion of some milk or water or undercooked food, and the third thing is an exposure to a rodent or its excreta. So these 3 things should be the thing. And when monsoon comes, as mentioned, you have mentioned the slide as a monsoon maladies, your thought should be towards 3 infections, 3 sets of infection. One is, and walking in the streets where your flooded water are there, you have the excreta of the animals, you have leptospirosis, think about leptospirosis. Ingestion of water, contaminated water, think about cholera, think about hepatitis A, think about enteric fever, other infections, enteric infections. And an increase in the number of mosquitoes will lead on to your dengue, malaria, and probably your other JE also can also be a possibility in these monsoon seasons. So think about in the next 6 months of these 3 infections. Thank you, sir.
Okay. Narmada, please proceed. Please. Yeah. So, of course, there may be clues like from the history. If you have a biphasic illness, you always think of something like dengue. Continuous fear, you think of enteric fear, etc. Next slide, please. Next slide, please. Okay. Now, most of the time, experienced pediatricians like Raju, Pani Raman, Somasundaram, and Nandini, they pick up the diagnosis the moment the patient comes into the clinic. And visual clues are very, very important in the diagnosis of tropical illnesses, because many a tropical fever is associated with some rash and some mucocutaneous manifestation. And we are going to see some pictures which should not be missed on examination, which may give clues, visual clues to the diagnosis. I'm sure with the insight from Dr. Rajaswani and Pani Raman, we'll have more information. Next slide.
You want to keep it as an audience poll, as you have mentioned, sir?
Audience poll is not possible with this. I just wanted some, I wanted to put a Google voting pad, etc. It's not possible. Just it. Now, this child had fever, and the doctor is putting the hand on the back and releasing the fingers. This is the physical finding. This is the physical finding. Okay. And this girl who's wearing a bracelet in the ankle got some rashes in the leg and she's in shock. Whereas the one on the right, this child has recovered from an acute febrile illness and is having a rash. The parents are very much worried. The question would be, next slide, please. What is the most likely diagnosis? Is it chikungunya? The moment you get a rash, we always think of chikungunya. And the child has got shock or severe illness, we always think of meningococcemia. We all know EBV and CMV are the twins which cause rash. And of course, dengue is very common. What is the most likely diagnosis? Yes, Raju and Paniram.
And In this case, I believe you mentioned this is the recovery phase of one illness.
No, the
So,
one on the right is the recovery phase.
phase.
The one on the left is in shock.
Yeah, they take the one on the right, which is the recovery phase. You find islands of the pallor and then the rashes. This normally you see in the recovery phase of dengue on the 6th or 7th day. And I usually tell in my rounds to the parents that your child is going to recover in another 1.5 days. This is the normal thing. It happens on the 6th or 7th day. Probably many of the practicing pediatricians will also have the same kind of experience. And one on the left, Dr. Paini can take.
Actually, the previous slide, please. Previous slide. Actually, as you say, actually, the dengue has 3 phases. We all know febrile phase, critical phase, and recovering phase. During febrile phase, the child will be erythematous. When you put the stent, you can see the impression of the stent. When you put your hand, you can see the impression of the hand. It is known as erythematous, completely erythema, full red, red palms and soles, red face, red body. So this is the active febrile phase. The dengue can have the rash like this, a simple erythroderma or erythema. Next slide, please.
Just a minute, sir. People are saying that they're not able to see the slides. I'm just stopping and resharing it, sir.
Okay.
Yeah. What is the problem?
I hope they're able to see.
Yeah. So this is mainly during the first febrile phase, the erythematous skin, and you can see the impression sign, whether the hand or even the stent. When you put the stent, you can see the impression of the stent. Next slide. Next slide.
Yes, sir.
In the left is mainly comes the critical phase. In the critical phase is the phase where there will be petechiae and purpurae and all these things. So you have mainly there is thrombocytopenia with the petechiae and everything. Even when you are not able to see the petechiae, you can elicit by tourniquet test. Comes the critical phase. Then the last thing comes as Raju sir told, it is mainly the recovery phase. There's the islets of white and the sea of red, and with the itching. This is a very good prognostic sign. Whenever the patient says the itching, it indicates the patient is recovering from the dengue. These are the 3 phases with the 3 types of skin lesions in a dengue, which we see commonly.
Okay. Now, it's very important to look at the skin in dengue. Very, very important. As rightly pointed out, different rashes can occur. The moment the child starts developing itching, you can start dancing. You can discharge the child. You don't have to do any blood counts. Itching is a sign of recovery. It's very peculiar. In fact, the pathogenesis is still poorly understood. Why that occurs? Recovery phase. There are 2 other clues in the recovery phase. One is the rash which is shown on the right side. Islands of white area and islands of red area. It's not an acute disease. Unlike the early left-sided slide which shows petechiae. Third thing is sinus arrhythmia. 4th thing is bradycardia. 5th thing is depression. Child will be depressed. I've seen many a child, particularly older children, on the recovery day of dengue, they'll cry. These are all important signs of clues to the physician that the child or the adolescent is recovering from dengue. Okay. Next slide, please. Can you go to the, yeah. Now, this was a young infant who had fever, high-grade fever, 2 to 3 days. Other than fever, what the mother complained was that the baby was constantly crying. Mother also had fever, high-grade fever simultaneously. This baby had a rash like what is seen in the left in the face, and also rashes in the feet, like what is being seen here, projected here. Can you have the next slide, please? And this is an older child who had fever, joint pain, and had a rash like this on the feet. Next slide, please. What is the tropical infection that this child is having? Is it dengue, chikungunya, leptospirosis, or typhus? These are the 4 things one is going to think of.
And
yes, Dr. Raj.
Yes. with this kind of hyperpigmented rashes, especially over the nose, ear, the pinnae, and the swelling and the extreme tenderness and limitation of the movements. In my experience, I found the left ankle joint is more involved than the right, but the picture shown here shows the right ankle joint. And this is very common thing in chikungunya. And the another good history is the proximity. The mother had, child has. So this occurs in proximity. You will find a hamlet of the group of people in a particular area suffer from that. And the same history will be there with all the people and same kind of presentation. That is unique with chikungunya. And we had a neonate who presented exactly like this with a hyperpigmented nose, and this we had presented in the ID journal.
And usually around 10 years or 15 years, I don't remember, we had an extensive chikungunya outbreak in the state, Tamilnadu. And those days, the characteristic things is a very short fever, 1 to 2 days, very hectic 1 to 2 days. And mainly the bullous, vesicular bullous eruptions in the, particularly in the limbs. It is very characteristic. And even the newborn and everything, when they heal, they will heal with hyperpigmentation. That is known as a chick sign, which is shown on the face and nose is known as a chick sign. But it will occur only during the recovery phase. That is known as chikungunya. But after that, we had not seen much after 10 years. So for the past 10 years, not seen much. Only during those outbreaks, it was a very good experience of chikungunya. Even with the newborn, we are having neonatal chikungunya very commonly.
Very common.
Okay, Dr. Nandini and Dr. Somasundaram, please, from in your experience, what are the types of rashes you have seen with leptospirosis and scrub typhus? Dr. Somasundaram and Nandini.
So with
yes,
please. That is in scrub typhus, we have seen at least in the rickettsial, sir, I have seen like scrub typhus, I've seen more of some Rocky Mountain spotted fever where we have seen rashes involving the palms and the soles. And also some of the children, because of the high degree of vasculitis and the endothelial area where this rickettsia multiply, the endothelial injury and then causing narrowing and ischemia, I've seen children even presenting with something like gangrene.
Sir,
Dr. Somasundaram, in ICH, you would have seen lots of cases of scrub typhus and leptospirosis. What sorts of rashes you had seen?
Sir, leptospirosis, it is like a purpuric lesions can occur with a maculopapular rash. The characteristic feature is an associated conjunctival hemorrhage in leptospirosis. In scrub typhus, we usually talk about the eschar, which is that entry point, but we also have a trunk trunk rashes which are maculopapular. Sir.
Okay, very well said. In scrub typhus, you can get almost any types of rash. The most commonly seen skin manifestations, of course, eschar at the site of entry, as pointed out rightly by Dr. Somasundaram. But you must also remember, scrub typhus can cause thrombocytopenic purpura. Scrub typhus can cause vasculitic rash. And as rightly pointed out by Dr. Nandini Kumaran, the rash may involve palms and soles, like Langerhans cell histiocytosis or syphilis. And it can also cause gangrene and discoloration, almost like, meningococemia. These are the types of rashes which can occur in scrub typhus. Leptospirosis can cause a maculopapular rash or petechia. And immune complex formation can result in any type of rash, even in leptospirosis. Right. Next slide, please.
Sir, can I add 1 or 2 points, sir, in scrub typhus?
Please go ahead.
Like Raju sir told, in my area, the commonest is scrub. followed by dengue, which is not so common. These two are the tropical fevers common in our area. So when a patient comes with a fever of 1 week duration or 7 days duration, modan, puffy face and puffy with minimal edema of the limbs, immediately we can say, and not toxic and ill looking, we can say mostly we are dealing with a scrub. So scrub we can diagnose by when the patient is entering our chamber with a history of fever of 1 week, with a puffy face and puffy limbs and not toxic, and with having your look, put the abdomen, there will be hepatosplenomegaly. Then you search for the eschar. Eschar can be there, may not be there in 50%. Number 2. In India, there are 2 types of rickettsial infection. One is scrub typhus and Indian tick typhus. In Tamil Nadu, scrub typhus is the common. Tick typhus very rarely occur, particularly in the Coimbatore belt and Pollachi and Tirupur. Some people refer the patient to me mainly with the pictures. For example, what Madam told is mainly the spotted fever type, which is very common in particularly in the Madhya Pradesh and Maharashtra, where usually by the 3rd day or 5th day, you'll have a maculopapular rash going for a palpable purpuric rash, like a leopard sign, having in the palms and soles, like it is like a sirtha mari irko. So the leopard sign, and definitely we can say it is a spotted fever. If you are not treating, they will go for the gangrene, so known as Khan-Kappe disease in particularly in the Maharashtra and North Karnataka, which is not common in Tamil Nadu. So there are 2 types. Scrub typhus mainly eschar, which is not seen in tick typhus. Tick typhus mainly the spotted rash, where the eschar is not present. But for both the treatment, doxycycline.
Yes, sir. GN. Typhus.
Okay. Raju, this child, 4-year-old, had fever, cough, cold, and rashes like this, and mucous membrane was like this.
Okay. So I find the morbilliform rash, we can call it as exanthem, and it is being preceded by one thing called the enanthem or complex spots. And we used to see in those days lots of sago grain-like things, especially in the anterior tonsillar pillars, which I feel we are not seeing those many nowadays. But in the past week, I had been seeing nearly and also reporting lots of the measles-like illness, 3 days fever, 4th day rash. And by the time I see, I don't find any enanthem. They come with exactly the cephalocaudal progression. The one important thing is the post-auricular node, which is always palpable. And this is measles.
Okay,
and
next slide, please.
Measles has to be reported for the people who are practicing and who are listening. Measles is an illness which has to be reported to the public health authority.
Okay, it's very important. Where measles surveillance is going on, we all know that in Mumbai there is an outbreak of measles killing quite a few children, and you can easily do measles IgM. It's not a very costly test, and you must report to the authorities. Raju, what about the boy on the left side, adolescent boy with skin lesions and fever, low-grade fever?
Yeah, he has got lesions of all kinds, like vesicles, bullae, the maculopapular rashes, and it's a pleomorphic thing, especially oriented to the trunk. This is a chicken pox, and the thing is,
why not it be monkeypox? New tropical infection. Why not it be monkeypox?
Could be. I have not come across anything. My experience is limited. And this occurs 1 day fever, the 1st day rash, think of chicken pox. It also starts with, it starts like measles, but 1st day fever and rash is chicken pox. The mnemonics, So 1st day fever, rash, chicken pox, 4th day fever and rash, measles. And the one on the right is probably the SJS or 10. Both are being described together nowadays. The one with the more than 30% exfoliation of the epidermis, we call it as 10, toxic epidermal necrolysis. Less than that, we call it as SJS, probably a hypersensitivity reaction to many drugs, especially the antiepileptics and the NSAIDs.
Okay, that slide is put mainly to make it clear to the audience that drug fever is also a type of tropical fever. Just because a child develops fever in the tropics, you should not think of infections alone. You should think of drug fever also. Next slide. Next slide, please. Yeah. What about This child had, as Paniraman pointed out, the slide on the left shows a young infant who was hardly 90 days old, who came with fever, hepatosplenomegaly. The fever subsided and had anemia. So we did a serum iron and peripheral smear. We are awaiting the reports. Child suddenly developed respiratory distress and shock and convulsions. The junior most doctor picked up the SR as seen in the right lower chest. 1 day of doxycycline, child recovered. As Dr. Paniraman said, SR is something which you can't afford to miss, and it is often elusive. In fact, after dengue came, pediatricians started counting the pulse rate and looking at capillary refill time. After scrub typhus came, pediatricians started looking at all the corners in young children, looking for the SR. The important point that one must remember, SR in children, unlike in adults, it doesn't occur in the exposed parts alone. It occurs in various regions like postauricular region, groin, scrotum, right? And around the umbilicus, sometimes in the vulval region, axilla. These regions we don't examine at all. In routine practice, we just look at the neck for nodes, look at the throat, palpate the abdomen, etc. So once you have an undifferentiated fever, at least for 3 to 4 days, we should always look for SR. And if it is present, it gives the diagnosis. And SR in our own series was present only in about 60% of cases of scrub typhus. Absence of SR does not mean it is not scrub typhus. Next slide, please. Okay, this is a child who had pneumonia like this, and the SR was close to the scrotum. Who look at this area in routine practice? So that is a message. We should look at all corners for SR in fever, in tropical fever. Next slide.
So one thing is we can ask the parents whether they had seen any skin lesions. Because
the parents also might not have noticed these areas. That is the problem.
Usually they will say, but they will say, that's what they say. So we ask them, so sometimes they come, but otherwise we also do a head-to-foot search.
Agreed. This boy had fever, had irregular heartbeats, okay, had a murmur, and these are the skin lesions. Paniraman sir.
Subcutaneous nodule indicating active carditis.
This is a subcutaneous nodule, extensive, and this boy had severe rheumatic carditis with cardiac failure. The presence of subcutaneous nodules should not be missed. Unfortunately, in the tropics, rheumatic fever continues to occur. Next slide. Okay, the one on the left, for want of time, we'll move on. The one on the left is an exudative tonsillitis and a rash due to EB virus infection. We should not forget the twins of EBV and CMV, which can cause exudative tonsillitis and rash. Next slide. Okay, this is the leptospirosis, the hemorrhagic conjunctivitis. And these children may have jaundice, may have vasculitic rash or a petechial rash. Of course, it's very much uncommon in Chennai, but it's very common in Mumbai. Next slide. Okay, now let us move on with the undifferentiated fever case. Dr. Raju and Paniraman, you have in your practice a child who has fever for 2, 3, 4 days, undifferentiated fever. What tests will you do? Urine routine, CBC, CRP, and CBC, and the so-called tropical fever panel. Tropical fever panel. If you go to the net, there are at least 15 kits which are being marketed. And finally, somebody may experience like Paniraman will say, I won't do any tests. Yes, Raju and Paniraman, you solve this question.
Okay, and I take your history as 3 days fever, undifferentiated febrile acute illness, and I'll vote for the urine routine, which you already said it's often missed in the day-to-day practice, and better to do the dipstick test, not the urine routine, which is being done in many laboratories. Do the dipstick test, which can even avoid lots of cultures. You concentrate on the nitrates, you concentrate on the leukocyte esterase, and don't bother about the number of pus cells, number of pus cast, and those things. The simple leukocyte esterase and nitrates can pick up lots of urinary infections, even from the dipstick test from the side lab. That is one thing. And if I am given liberty from the experienced panel or from my patient, I'll go one step further to do CBC. It's 3 days, not that the patient is going to leave you with the urine test alone. And if he permits me, I'll go for the CBC. In that CBC, I won't concentrate on the total count and those things. If the total count is low in the early stage of the illness, it could be viral, most probably the dengue. And I'll also concentrate on one thing which is not being done by many, that is the absolute monocyte count, which when it is more, this is an early indicator of sepsis. And the absolute lymphocyte count is one thing, which if it is more, you can think of the diseases like acute bronchiolitis, EBV and all. And if it is less, I'll also think of dengue. This is the normal thing which I found in my practice.
Paniraman, your comments on tropical fever panel.
Tropical fever panel is for people like Mumbai and for you people, sir, not for us.
Why for me? For me.
So for us it is, particularly when you are in KKCTH, or people like Nandini Kumar and Coimbatore, not for me.
Okay, let me ask Dr. Somasundaram and Nandini Kumaran, are you doing any of these fever panels, either of you?
No, sir.
No. Why?
No, sir.
Why no? Why no?
Sir, if there is an evidence, we go for the specific test from the CBC or the CRP, which gives a clear indicator, and from the history and the clinical examination findings, we do the specific test which is needed in specific to that tropical fever, which we expect from the child, sir, rather than going in for a panel which costs the child or the parent more costs.
Okay, Nandini. Madam,
muted. You are
muted, madam.
Madam,
okay.
Now, industrial is coming to you.
I agree with Dr. Somasundaram. We do not do the fever panels. I think we go by repeated examination, clues from a thing, and then probably choose tests accordingly, rather than going for a very expensive fever panel test.
Okay. Very, very appropriate answer from all the experts. I would like to add that these tests are not to be done today for few reasons. One, these tests have not been standardized, including the one I projected, the BioFire with the reputed company. That is not, this test has not been validated in field settings and is not approved by the FDA. So until that is done, I think it will be a waste of money. Two is that it's very expensive. It's very expensive. The third is that in a child who's not very ill, what is the point in doing tests for 19 viral illnesses, including COVID-19? You're not going to have any use in the treatment. You should look at only treatable causes like leptospirosis, typhoid fever, maximum bacterial infections, rather than for Zika and other things. It's not going to help. So it's better not to do these panels at all as of today. But I'm sure in the next 10 years, the test will become standardized and we'll have panels for 19-20 diseases. Let us move on to the next slide, please. Okay. Now, case 2. Dr. Somasundaram, 1-year-old child with fever, rash on day 3. Is this a tropical infection? and how do you approach? What are the tropical fevers with rash that you see in day-to-day practice?
Sir,
please.
So,
next slide, please.
This is the second syndrome actually, which we'll be discussing later. So they were having seen the undifferentiated fever. We are moving on to a specific clue which we get, that is the rash. So the rash is a very clinical and a very important clue which to the clinician to diagnose a fever. So I will look into 3 Ds when I see a rash. The day of appearance of the rash is the first D. Either it is a first day rash, or we have in undergraduate days we have had the pneumonic. That's the very sick people must take drug treatment. So the very sick, V for varicella is day 1 rash. S is scarlet fever. Second, day 3 is pox, that is smallpox. Day 4 must is measles. Day 5 it is must take, that is typhus, that is a scrub typhus. And the day 6 is the evanescent or the clearing dengue, which Dr. Raju sir has mentioned, that is the 5.5 days or the 6th day rash. And the 7th day rash is the endemic fever, which is usually not seen in dark complexion people. So I will first look into the day of the rash. The second will be the distribution of the rash. The second D will be the distribution, whether it is a centrally located rash or it's a peripherally located rash, or whether it is a cephalocaudal progression of the rash is there or not, I will be looking into. The third thing will be the distinctive character of the rash. What is the third D will be the distinctive character. What character the rash has got, whether it is a nodular rash, whether it is a vesicular rash, macular rash, papular rash, or the petechial rash. So all these 3 Ds will help us to make what type of illness or what type of viral exanthem, or whether it is a bacterial or whether it is an other zoonotic disease which we are dealing with, will be with this. These 3 Ds will help us to give some information on that, sir.
Okay, it's important to obtain proper history, chronology of the rash, and then make a diagnosis. Next slide, please. Dr. Nandini, 5-year-old child has got fever for 5 days. There is some tachypnea and cough for 2 days. You find that the saturation is 80% and an X-ray is taken. These are the X-ray findings where it shows bilateral fluffy infiltrates on either side. What tropical illness could be causing this sort of fever and respiratory symptoms? Dr. Nandini.
This is almost a 5-year-old child with predominantly fever and respiratory symptoms. Child is already hypoxemic with very low saturation, and the X-ray, as sir said, shows a fluffy infiltrates bilaterally, more in the upper and the mid zones. Maybe the lower zones laterally, they are little not much affected. Still, you can see the cardiophrenic, costophrenic angles and the diaphragm. So it is not really a patchy consolidation. It's more of a sort of a ground glass flare from the hilum towards the periphery. And this suggests sort of an interstitial pattern. Most likely, I would consider a viral illness like a influenza.
Doctor, next slide, please. Yeah.
Influenza.
Yeah. Okay, please
That
go
will be
ahead.
the first thing. Though we can have other bacteria causing pneumonias, but this is not really patchy. The other differential diagnosis always will be for community-acquired pneumonia, will be streptococcus, and in older children, the atypical microorganisms. We also see some of the tropical diseases where they get respiratory manifestations a little late as the disease progresses, as in scrub typhus. They can initially present with fever and other things, and around the first week of illness, they can go in for respiratory manifestations. That is the ARDS, acute respiratory distress syndrome presentations, where you can see it with both scrub typhus, leptospira, and also complicated malaria like the falciparum malaria.
Okay, nowadays we have to add adenovirus also in the differential diagnosis.
Yes.
And of course, for these patients, we always add doxycycline to cover rickettsial infection. Next slide, please. Dr. Raju, 8-year-old child comes to your nursing home with progressive lethargy and status epilepticus. He is living in a tropical area. What tropical fever is this, and what tropical infection is likely to be there in the boy who has got fever and coma with status epilepticus? How do you approach? Next slide, please.
8-year-old boy with 1-day fever and progressive lethargy and status epilepticus indicating the lesion is in the neurons, and it's an encephalitis. Now, mostly we think of the prevailing viruses like JASB, which we had a big epidemic in Tirunelveli when we were students way back in 1970s, late 70s rather, and herpes simplex encephalitis, which is prevalent throughout, and other rare viral encephalitis, which are being diagnosed now with the kind of card test which we do, the panel which we do now. And let us not forget the common meningitis syndromes like strep pneumonia and rare things like Neisseria meningitidis and HIV, which after the vaccination is rarely found nowadays, and also the common enteroviruses in the topics. And we should not forget the cerebral presentation of things like cerebral malaria, scrub typhus, and typhoid encephalopathy, which rarely probably produces seizures. But the vasculitis, things like scrub typhus, cerebral malaria, and also dengue with encephalopathy also, we had seen in quite a number of cases.
Very well said, Raju. Nowadays, the current guidelines on tropical fevers in India suggest that when you have a child or an adult, young adult with acute febrile encephalopathy, we have to cover for bacterial causes like pneumococcus and meningococcus, cover for HSV, that is ceftriaxone plus vancomycin plus acyclovir. And if you have a doubt it is falciparum malaria, on clinical grounds or on the labs, artesunate. And also you give doxycycline or azithromycin IV to cover scrub typhus. That is an empirical choice for somebody who has got acute febrile encephalopathy who is very ill. Next slide, please. Case 5. Dr. Paniraman, this child has fever for a week, profuse vomiting, oliguria, lethargy, tachypnea, melena, all this one after another in a few days. On examination, the child is pale, blood pressure is low, 70/50, saturation is 90, the child is icteric, he's got hepatosplenomegaly. What do you think is a likely diagnosis syndromically, and how do you approach? See, it's one thing after another. Renal system is involved, respiratory system is involved, GI system is involved, circulatory status is involved, icterus is there, organomegaly is there, anemia is there. What more you want?
So
Next slide, please.
most of the tropical fevers can produce this, sir. For example, dengue, when you are not treated properly, when it goes for dengue shock syndrome, it finally leads to multi-organ dysfunction and present all the things by the end of the week or fifth day, number 1. Number 2, in malaria-prone areas, falciparum malaria can do this, number 2. Number 3, when you are not treating a scrub, not identify a scrub in the first week, in the second week, early second week, it can lead to all the multi-organ dysfunction with all the involvement, number 3. Number 4, very rarely leptospirosis, that is Weil's disease, icteric forms of Weil's disease with particularly hemorrhagic ARDS, myocarditis, icterus, that is a icteric form of leptospirosis can do this. So all the tropical fevers can do this, and sometimes all these tropical fevers can be a trigger for HLH and can finally present like this. So tropical fever, depending upon the situation, season and location and everything, with the supporting investigations, you have to decide which tropical fever is causing this problem. So that way we can easily we can differentiate one after the other.
This is a classic case of a tropical fever causing multi-organ dysfunction. It can be bacterial, viral, or it can be an autoimmune phenomena also, like HLH. That's the point which Paniraman was rightly pointing out. Next slide, please. Yeah. Now, having said all this, we must remember in practice, whenever a child in tropics has got fever, we should adopt a syndromic approach. Can I have the next slide, please? The syndromic approach, Raju, what do you think is the correct syndromic approach when somebody in tropics comes with fever? How do you classify?
Having seen all the presentations, let us see one by one. The first is the acute undifferentiated febrile illness. That was the first, in which we saw the common viral infections plus the common tropical infections which present with high fever in the initial phase. And second, we saw the fever with rash. And third, probably we saw the fever with thrombocytopenia, and we saw various rashes and fever with thrombocytopenia, and which can present with any kind of tropical illness, which we listed already. And fever with acute respiratory distress, as Dr. Nandini put it, think of an acute viral prevailing infections like H1N1, and things like scrub typhus, lepto, and those things can also present. Let us not forget the common strep pneumoniae, the bacterial infection, and the febrile encephalopathy. Think of the prevailing viral infections plus rare viral infections, and let us not forget the autoimmune encephalitis as well. And the fever with multi-organ dysfunction that Paniraman listed a few conditions, and always think of the common things. And these are the things I think will have the 6 approaches, like undifferentiated fever, fever with rash, fever with thrombocytopenia, fever with acute respiratory distress, febrile encephalopathy, and fever with multi-organ dysfunction.
Next slide, please. Next slide, please. Okay. Now, Dr. Paniraman, with your decades of experience, how do you do a physical examination in tropical fever, and what are the most common missed clues? Dr. Paniraman. Can I have the next slide?
So there is no specific thing, sir. It is we should be an undergraduate when you go for the examination of a tropical fever case, starting from the vitals and starting from the particularly, we should start that is seeing the dorsalis pedis pulse. That should be the first pulse should be seen in any tropical fever, because whenever dorsalis pedis is feeble, it indicates, and the child is having a very chilled peripheries, it indicates mostly you are dealing with a dengue. And apart from the vitals, you have to see from the head to foot. Already we have stressed about mainly the finding of the eschar. Already we have stressed about the skin signs, which we should not never miss. Already we stressed about the eye signs. So skin, eyes will be a very good clue, and the look of the patient as well as the vitals will all give you the clue. Then we go for the systemic examination, go for the hepatosplenomegaly plus or minus, and there is a respiratory system plus or minus, and the CVS. So all the things like a routine undergraduate student, you should go and examine, and mainly stressing on during the season, stress on the vitals, stress on mainly the temperature of the peripheries and the pulse, particular dorsalis pedis. Try to catch the fall at the patient's feet. That should be the motto during the tropical fever. Then naturally you will never miss a case of dengue shock syndrome, because dengue shock syndrome, particularly when you look at the face he will be completely awake, but still he will be in shock. So that is the speciality of dengue shock syndrome. So you should be very careful to look at the pulses, and as I already told about the scrub too.
As Paniraman said, it is the reverse. Previously, patients used to prostrate before doctor. It is the reverse. You have to palpate the dorsalis pedis now.
Okay. Having discussed the etiology and having discussed the approach to history taking and physical examination, Dr. Somasundaram, can you suggest an algorithmic approach to tropical fever to make it easy for the audience to follow in practice? Dr. Somasundaram, can we have the next slide, please? You can open up the slide, Dr. Armada, fully.
So whenever we encounter an acute febrile illness, a child presenting with an acute febrile illness, we have to find out whether we'll be asking you, I will be telling the parents, we have only 3 holes. One is the airway, the other is the mouth, and the third is the urinary opening. So if you have symptoms related to the 3 holes, we are going to diagnose your infection regarding the 3 holes, that is the respiratory system, the gastrointestinal, or the urinary infection. If you have no localized symptoms or signs suggesting that, then it can be an acute undifferentiated febrile illness. The first which can be ruled out by a main smear or an RDT negativity, is a malaria, which can be first ruled out. Once the malaria is ruled out, we have the other 3 common causes, like a viral, a bacterial, or a parasitic. A viral, 2 things. One is an airborne influenza. The second is an arthropod-borne viral infections. We all know that is like malaria, dengue, and those things. Bacterial, we have already discussed the pneumococcal, all those bacteremia. Main thing not to be missed is an endemic fever and the leptospirosis. And for example, zoonosis, which includes leptospirosis. In parasitic, we have to think about hepatic amoebiasis, since malarial has already been ruled out from the parasitic infections. So this will be the approach, sir.
Excellent, Dr. Somadram. He has made it very simple. Listen, please go back to the slide, Dr. Ananda. If you see the slide, first thing is the commonest is only viral and perhaps UTI. They don't require any intervention. Malaria, in fact, somebody has put in the chat box, what's the incidence of malaria? I have not seen a smear positive malaria for the last 4 years in Chennai. It is rare. In fact, we are fortunate to have less of malaria, but unfortunate to have more of dengue in Chennai. Malaria still exists in Tamil Nadu, somewhere in Dharmapuri, Ramanathapuram, but it is far less than what it was a few years back. Even falciparum malaria comes from Sri Lanka to Rameswaram and then to Ramnath district. That's what is happening. And malaria does exist in large numbers in the northeast, Mumbai, and even in North Karnataka, Andhra Pradesh, etc. In Tamil Nadu, by and large, malaria is rarely seen, and falciparum in Chennai city is exceedingly rare. If at all malaria occurs, it is mostly only vivax. That is one. Second is, previously we used to have a diagnosis of clinical malaria. Somasundram, do you make a diagnosis of clinical malaria and start giving chloroquine or artemisinin in lumefantrine combination these days?
Sir, when I was in ICH, we used to do that left and right, sir, before 7 to 8 years. But in my clinical practice nowadays, I'm not doing that, sir.
Okay, actually, you are not wrong in having done that, because that was the recommendation in the National Malaria Eradication Program those days. In endemic area, they used to suggest smear and chloroquine. I think that practice is now stopped, because the term clinical malaria is not there in the National Malaria Eradication Program today in India. There is no role for either artesunate or your artesunate combination, lumefantrine combination, or for empirical chloroquine without smear positivity for malaria. The next thing is, when it comes to bacterial infection, enteric fever, you have to do a culture. That is very much required, and Vidal is to be condemned. And of course, arboviral influenza, adenoviruses continue to occur. They mimic bacterial infections. We have a problem. Among zoonoses, leptospirosis, okay, and brucellosis are the two often forgotten zoonoses. And of course, I have a question on leptospirosis towards the end. Hepatic amoebiasis is very, very rare. Okay, that is regarding the approach. Okay, can I have the next slide, please?
Sir, before that, can I add one more thing,
yeah,
sir?
Please go ahead.
Previous slide, please.
Please go to the previous slide, Dr. Narmada.
This is with respect to clinical and theoretical classification. When a patient comes to us by third day or fifth day, because we will not be able to classify in this way for various reasons. So immediately we look at some basic investigation, just a CBC and urine. Then afterwards, urine, we know if it is a UTI, urine will be positive. After the CBC, you can bifurcate into two things. Either you are having a neutrophil leukocytosis or a leukopenia. All the tropical infections will present with leukopenia, less than 5,000 total count. Whereas all the conventional infection like itis, like pneumonitis, pyelonephritis, arthritis, septic arthritis, osteomyelitis, all itis will have leukocytosis. When it is there, you go in this direction. When leukopenia is there, you go in this direction of dengue, typhoid, typhus, as well as all the things. But only exception is leptospirosis is the only tropical infection presenting with neutrophilia rather than with leukopenia. That is the only exception. So all tropical fevers will have leukopenia. All the conventional fevers will have leukocytosis. That is the one thing which we can easily bifurcate. Then with the leukopenia, then you see leukopenia with anemia, leukopenia with thrombocytopenia, leukopenia with polycythemia. You immediately know leukopenia with thrombocytopenia with high hematocrit, it is dengue. Leukopenia with thrombocytopenia, it is scrub. So like that, you can easily differentiate. So use this CBC tactically to go for the specific investigation after the thing.
Dr. Painiraman, with due respects to your views, I always believe that CBC has very little value on day 1 or 2 of fever.
So I am telling
You
you,
know,
day
in
three
fact,
and day
I'll tell you. You know, leukocyte WBCs are like constables. They'll be there if the CM is visiting the place, or if there is fire, or a security to governor, or if there is a communal riot. Okay. We have seen typhoid with 25,000 counts. Okay. Dengue with 25,000 counts. It can occur. CBC basically, unlike urine routine, has very poor diagnostic utility in the first 2 to 3 days of illness. It adds very little to the value. And more than CBC, CRP is another useless investigation. At least adenovirus has taught us that CRP is another useless test for 1, 2, 3 days of fever, except in newborn. Even in newborn, it is going out of vogue. So that is my humble submission.
But
however, somebody like you, good clinician, does not require, if you ask me, CBC at all.
So,
Okay?
but I beg to differ, sir. But I beg to differ. But serial CBCs are definitely very useful, and particularly when you have neutrophilia, leukocytosis, enteric fever is very unlikely in the first week.
No. And in our own series of cases, 25% of our enteric fever have got counts over 15,000. 25%. So I don't think leukocytosis rules out enteric fever. You know, it's okay, right? We agree with you to disagree. Thank you. Then, if you have a child with tropical infection, the first aim is to assess and stabilize ABC. If you identify a focus, you treat it. Like Paniraman said, pneumonia, pyelonephritis. And if there is an encephalopathy or respiratory distress, give antibiotics and supportive measures. And then if a focus is not identified, go for risk factors, geography, season, associated symptoms, etc. Next slide. Next slide, please. Yeah. And investigations, as Paniraman said, start with CBC, then go for LFT, RFT, CRP, urinalysis, X-ray test. Then comes rapid diagnostic test, dengue, NS1, CART test, H1N1. Then if you have the rapid test suggesting diagnosis of malaria, treat. Dengue, treat. Typhoid, treat. And that all these rapid tests don't give you a diagnosis. If the child is sick, more than 4 or 5 days of fever, empirical ceftriaxone plus or minus doxycycline or azithromycin, and you do scrub typhus IgM, and perhaps consider ultrasound abdomen and bone marrow like a PUO, whether it is tropical fever or non-tropical fever. Next slide, please. And before that, to sum up, next slide, please. To sum up, basically, we must remember the most common tropical infections continue to be viral, like arboviral infection, typhoid, malaria, and zoonosis. Stepwise approach with good history, good clinical examination, basic laboratory data correctly interpreted, and looking for malarial parasite with the peripheral smear and blood count in all patients with undifferentiated fever will help you get a diagnosis. Oh God. Sorry. Yeah. 1 minute. Can you go to the next slide, please?
I have gone to the next slide, sir.
Yeah, no. Suddenly it is not there. 1 minute. It is gone. Yeah. It's not coming in the box. I don't know. I mean, oh God. No, suddenly I'm doing it with my phone. I don't know. Just a minute. Yeah. And early presumptive antibiotic therapy should be started if there is bacterial zoonosis until results come. In treatment for enteric fever, we have to take into care the prevailing drug resistance in the choice of antibiotic. Next slide, please. Empirical therapy with cephalosporin and doxycycline. We must remember in 1950s and 60s, people used to criticize the combination of penicillin and tetracycline for pneumonia, thinking that it increases mortality. Today, in undifferentiated fever, 5-6 days, if you suspect rickettsial infection, if you are not sure it is enteric or rickettsial, you are justified in starting a combination of ceftriaxone and doxycycline to cover tropical infections. And if there is a doubt about it, the presence of rickettsial infection, doxycycline would be an ideal drug because it will also add as a companion anti-malarial drug to attenuate if it is malaria. Next slide. And response to fever, response to antibiotics for tropical fever can vary. In general, if it is scrub typhus or any rickettsial infection, within 48 hours, if the fever does not subside, it's probably not rickettsial infection. It's a therapeutic response. Whereas in the case of enteric fever, we all are now seeing it takes around 7 to 8 days. And in diseases like melioidosis, it take even a fortnight. Of course, we have to inculcate the culture of culturing the blood rather than depend on useless serological tests like Vidal. And even if the fever responds to empirical therapy, a repeat specimen may be required in cases like mycoplasma, scrub typhus, to demonstrate a 4-fold rise in titer to confirm the diagnosis. And always you should review the diagnosis if fever persists in spite of appropriate antibiotic. And investigations like bone marrow always come to our rescue in difficult cases. Next slide. In the end, I would say tropical fevers are no different from, can we shut down the slides, please? Can we stop sharing the slides, please?
Yes,
Dr. Narmada? Yeah.
Yes.
In the end, we must remember that tropical fever is like any other fever. A child in the tropic may have a tropical infection, may have an autoimmune disease, may have a malignancy, may have a drug fever, may have a drug fever, which is pseudo fever also. So the approach should be very similar, and we should be careful in giving labels. Before I wind up, I have 2 questions to the expert panelists. Each of them can express their individual opinion. I'll start with the youngest, Dr. Somasundram. Dr. Somasundram, in your practice, when do you consider giving doxycycline in pediatrics?
So the
because
first
doxycycline is the mantra for tropical fever, isn't it? So when do you consider giving doxycycline in your practice, inpatient and outpatient?
the suspicion or the proof of a scrub typhus is the first indicator for giving a doxycycline in my practice.
Any other?
A leptospirosis will be the second choice, which I will consider doxycycline initiation.
Any other?
Brucellosis.
Nandini, yes, you can add.
Brucellosis also we can consider, though it's not the.
Any other? Any other?
Along with artesunate.
Artesunate for malaria.
Malaria. Yes,
Yeah,
Paniraman, any other? Paniraman, any
So
other?
mycoplasma, which is not sensitive, that is azithromycin macrolide resistant mycoplasma, atypical.
Any other? Any other? Yes, Raju.
It is a cocktail in in combination. You give antiviral, antibacterial, antituberculous, antimalarial, and give doxy also. It is being mentioned in Nelson in the under the chapter rickets. It has been there in the previous editions. I do not know the present thing.
Yeah, I agree with all the panelists. In fact, doxycycline, in addition to all these effects, has also got anti-inflammatory effects, like chloroquine. So if your child's fever is settling down, it may not be because doxycycline is working against the bug. It may be because of like an action like an NSAID also. But having said that, doxycycline is a wonderful drug. It's a wonderful drug. The reason is, the safety of doxycycline is so good so good. It doesn't have any dangerous side effects. Side effects like Steven Johnson are extremely rare with doxycycline. And in rickettsial infection, even in newborn, the American Academy of Pediatrics has endorsed the use of doxycycline. You don't have to worry about the teeth and bone. Let the child live. It's a safe drug. In addition to treating your scrub typhus, mycoplasma, brucellosis, doxycycline is a very good drug for skin and soft tissue infections. Is a very good drug for melioidosis also. Is an excellent drug for venereal diseases. Alternative drug for many venereal diseases. And it's a drug without much of side effects. So we can use doxycycline boldly in tropical syndromes. And most of the bugs which are covered by doxycycline are rarely grown in culture. They are only proven by serology, like mycoplasma, brucella, leptospira, etc. Okay. Question number 2. How common is leptospirosis in your experience? I'll start with Raju and Paniraman, then move to Nandini. And how do you diagnose leptospirosis? How do you treat leptospirosis in your practice?
As I said, it is very rare in my area. It is usually taken as a last choice.
Paniraman.
Sir, I don't know the actual prevalence or incidence of leptospira, but because as it responds to all the antibiotics which you give as a routine, all beta-lactam antibiotics, we may not be knowing whether the child has recovered from leptospira as such. Number 2. Number 3, majority are anictic type of leptospirosis, which is a mild form and usually responds to the routine antibiotics, unless a severe form which only needs the IV doxycycline or IV crystalline penicillin. And I think mostly it is an overdiagnosed condition previously in Chennai. Now it is also overdiagnosed, has come down. I don't know the actual thing, what is happening in things, because it needs a specific test like MAT to confirm the diagnosis.
Somasundaram and Nandini.
It's only very rarely. It's not, we don't see it very commonly at all.
Somasundaram.
When we do the fever investigations for a prolonged fever and hepatitis along with MAT positivity will be considered as a treatment option for leptospirosis, sir, when others are negative.
Comes as a pan, it's also in the panel.
Thrombocytopenia.
Though you don't agree that it's
No. I say two things. One is with Janani around, Janani has done published papers on leptospirosis. Okay. Now, 2 or 3 things you must remember about leptospirosis, which of course Paniraman already brought out. Leptospirosis is one spirochete which will respond to any damn antibiotic. Unlike other bugs like enteric, leptospirosis is not, generally spirochetes don't develop much of drug resistance, like syphilis. They don't develop much of antimicrobial resistance. Leptospirosis can respond to any drug, not only beta-lactam, doxycycline, tetracycline, azithromycin, erythromycin, clarithromycin, anything, roxithromycin, anything will work against leptospirosis. That is point number 1. Point number 2, the gold standard for leptospirosis diagnosis, the gold standard for leptospirosis, unfortunately, is not available for all of us. What is the gold standard? Is a culture. Culture is done only in veterinary labs. In human laboratories, because it's a biohazard, it's not done. However, today, in the several rapid test panels, it is not MAT which is there. It is a PCR for leptospirosis. In fact, in Mumbai, they continue to identify leptospirosis during monsoon in good numbers, unlike Chennai, mainly because they have started doing PCR. PCR is a very good test for diagnosis of leptospirosis. In fact, my prediction is that 5-10 years from today, PCR will replace cultures for diagnosis of diseases like leptospirosis, typhoid, and even brucellosis. That's what is going to happen. We are not going, and your microscopic agglutination test is a very, very unreliable test. Okay. The IgM test done after 5 days of illness is a more reliable test. The reason why they say microscopic agglutination test is not reliable because it is reported by the people who look at this microscope and report the presence or absence of agglutination. It's a highly subjective test. It's not reliable. In fact, I still remember Dr. Vasant Kumar once sent normal newborn samples to labs, and they reported leptospira present in the urine, in the dark ground elimination. So it's not reliable. It's not reliable. So we need better standard. My last question to all the senior panelists. Do you do Vidal in the diagnosis of tropical fever? Each one of you. We'll start with Raju.
Yes.
That's my last question of the day.
Yeah, I do Vidal. Yes. Also,
why do you do?
antigen.
Why do you do? When do you do?
After 7 days, once the antibodies are formed. That is the time they land with this.
Mani Raman sir.
No, sir.
Okay, Dr. Somasundaram.
No, sir. I'm not.
Dr. Nandini.
No, sir. Earlier we were doing, but now we have stopped given because
They
of
do
the
antigen.
Okay.
blood culture when we strongly suspect in the first week itself.
Okay, let me tell you, I have not done Vidal for the last 10 years. And if my PG or assistant does it, he takes it from me the next morning. So I don't think we should continue to rely on Vidal. It's a useless test. I mean, somebody may say, what if antibiotics are given? You must remember, even if antibiotics have been given previously, a blood culture yield is still fairly good. And if necessary for a PUO, you do a bone marrow. Bone marrow, even if the number of organs is very small, you will get the diagnosis. Okay. This got very poor sensitivity and specificity. Okay.
We send it for cultures and Vidal, and there is almost always a correlation when it is more than 320. It is almost always there. We can prove.
If your culture is growing, then why do Vidal at all?
Culture will take some time. It takes
So
minimum
what?
4 to 5 days.
So what?
Even at the
So
back
what?
tech.
I mean, if you start ceftriaxone with Vidal is negative, are you going to stop ceftriaxone and give only paracetamol?
It's not going to come down with ceftriaxone on the day one.
No. I mean, my sincere appeal to the audience, please stop you doing Vidal. And even the IgM test has very poor sensitivity and specificity. I think we should go beyond Vidal for tropical fever. With this, we will conclude the.
Only just
Only 3 questions, sir. If NS1 is positive, should we confirm with serology on day 7?
There is no need. NS1 is a highly sensitive test in the first 7 days. Okay, more reliable than serology. There is no point.
And the streptococcal rapid antigen test is useful.
Streptococcal rapid antigen test, it has got very good specificity and sensitivity to the tune of 88 to 90% in our own experience. And in those who have acute pharyngotonsillitis, in whom you suspect it is bacterial, if the rapid test is negative, there is no need to do a culture. You can straight away treat it as acute streptococcal pharyngitis.
How about ESRs? ESR.
ESR. Parniraman, ESR. Let him answer.
The ESR is mainly for the PUO, sir, not for acute fever of less than 7 days duration. So it is only for the thing. And one point I want to add, sir, all the tropical fevers will produce thrombocytopenia. But when you have a clinical picture suggestive of leptospirosis like thing, you add creatinine and CPK. If both are positive, like thrombocytopenia with the CPK high and creatinine, definitely you can suspect leptospirosis. That is a very good clue in the day-to-day side-by-side labs. That is a very good clue.
Incidentally, Parniraman, there is one mimic of leptospirosis which is being increasingly recognized in India, that is hantavirus infection. It exactly resembles leptospirosis. The same hepatorenal syndrome occurs due to hantavirus. In fact, in our hospital, Dr. Sarah Chandy, she has specialized in, she has worked in CMC and she has published papers on hantavirus. This hantavirus closely resembles leptospirosis.
So can we use cefotaxime instead of ceftriaxone?
Yes, definitely.
Cefotaxime instead of ceftriaxone. Let me tell you, the dose of ceftriaxone for enteric fever is 200 milligram per kg. It has to be used 50 milligram per kg 6th hourly, which is difficult. One. Two. Ceftriaxone is superior to cefotaxime for enteric fever because ceftriaxone is excreted through the biliary tract. And we all know typhoid is a disease where the bugs are present in large numbers in the biliary tract. Ceftriaxone is more effective.
Thank you, sir. I would like to acknowledge the presence of Dr. Emma Chandra Mohan, Director, Institute of Children's Hospital on this panel, as well as Dr. Balashankar, sir, President-elect IAP TNSC. Thank you so much for the presence, ma'am and sir, and you have been here since the panel started. Thank you so much. Now, over to Charani, ma'am. Can we conclude the panel? And
yeah. I think it was a wonderful session. It was I think I didn't even wink my eyes. It was so good to listen to sir and all the elite panelists. It was like a revision of first class. So it was really good. Thank you, sir. Thank you. And thanks to all the panelists.
Thank you. Thank
so
you,
much
everyone.
of practical points. Thank you so much, Balasubramanian sir, for accepting in spite of your busy schedule. I know it was worth waiting for you for 2 weeks to get this inputs, as well as Dr.
I will not say no to ID.
Yeah. Dr. Pandiraman sir for a very practical approach, and Dr. Nandini Kumar.
Myself and the SBS is 1 year junior to me, and we used to have a lot of fight when we were PG.
Still, it is the same. It is very nice.
I wanted to continue, but somehow you concluded.
The fight continues with Vaidal.
Remma ma'am, you want to add something, ma'am? You have added something. Dr. Remma ma'am? Ma'am wants to say
No, just want to thank all of you. I mean, for this late in the evening on a Sunday, I think it made very, very interesting listening to all of you. Thank you, SPS sir, and all the panelists for making it highly informative and interactive. Thank you so much.
Thank you, Dr. Emma. Thank you.
Thank you, Bala.
Thank you, Dr. Rajan. Thank you so much, Chandran sir. Thank you.
And to all the peripheral pediatricians, be aware of the area you practice, be aware of the season, and judiciously use and carefully interpret the CBC and urine and X-ray. We can definitely make 90%. We can treat with wonders. Thank you very much.
Thank you all for accepting.
Thank you.
Good night.
Thanks, Narmada. Bye.
Thank you, ma'am. Thanks.
Thank you all. Thank you.